thoracentesis, transudates, exudates. Sometimes in the lungs, the infectious material will create loculated, for lack of a better term, they're called pus pockets. And those pockets sometimes can necrose tissue, not in the airways, but in the alveolar tissue. And so you'll sometimes see things called, have you heard this term, empyemas?
Yes.
An empyema. Let me see if I can show you what it is. It's essentially a pus pocket. So it's an empyema.
Empanadas and fish fillets.
Nice.
That's how I remember the two terms. Empyemas, pus, and then fillet.
Fish fillets.
Irregular pathways, something like that. See? We want it to look good. Whoa. Empanadas. That's nasty.
Fish fillet.
Whoa, that's.
It's like least
This one right here.
Really?
to me. I've never liked fish.
So there's an empyema there, but it's also caused a left lower lobe pleural effusion. So not only is there a loculated pocket in there called an empyema, but it's also created fluid that you could do a thoracentesis. Now, when do you know to do a thoracentesis? You usually have to have more than about a liter of fluid because it's an invasive procedure. For the most part, they try to let the patient take care of them. Let the human body try to absorb that fluid. A small amount can be absorbed, but if it gets to be about 500 or 1,000 cc's or 1 liter, then they'll consider taking it out. But it's an invasive procedure. They try to let the human body do it if it can.
Do they get really sick when they're trying to take it back in?
Sometimes.
Absorb it?
Yeah, not always, but sometimes. So this is developed. This is an empyema that's developed into a pleural effusion.
Dang.
I want to see the.
But it just scaring him more, not cute.
I don't know.
You know, sometimes.
I know how to play it.
There's an empyema.
How can you tell when it's a empyema that goes into
Be
a
alive for that.
like how do you know that?
The pleural
Or does it
effusion
always start out that way?
will blunt the costophrenic angles. So it'll become hazy and the angle will be blunted or it'll disappear because fluid's gone to the lower level. So this is an empyema that stayed there. It hasn't developed pleural fluid.
Speaking of empanadas, that's empanada I had was probably
I don't think I've ever had an empanada.
pretty awesome.
What is it? Is it fruit in it?
They sometimes like dessert or like cheese empanada. Just cheese or just salsa or
That's smoker's lung?
And then empyemas, if you have pus pockets in there, empyemas can develop into an abscess. So this is an area that had an empyema. Usually you'll see a specific fluid-air interface. So you'll see white down below and air up above. This one's drained, and so now you're left with this pocket. This is an abscess that's been drained, probably. So secretions play a huge role in helping us to determine what we should do, when we should do it, if we should intervene, what the color consistency of those secretions are, how we approach trying to treat them. So an empyema. Have you heard of a chylothorax? That includes abnormal secretions as well.
Kylo Ren.
Chylothorax.
What is it?
You're saying that like with secret?
Kylo.
Star Wars.
Okay. So that kind of thought it might have been.
Yeah, that's not even
It's the Ren. Oh.
Kylo Ren from the newest one.
Yeah. Everything's just Ren, I thought.
Kylo Ren. They call him Ren for short.
Here on this CT scan, so chylous fluid is in the pleural space. It's not in the parenchyma like an abscess or a an abscess or a empyema. This is developed fluid in the chest, in that lower. So that's the spine, that's the sternum up above, and that lower part in the, I don't know if that's anterior, posterior. I'll just assume it's in the left lung. So left posterior lung is full of fluid and secretions, probably in the thorax. But this is child fluid, which is usually a white fatty kind of a fluid. It's different than what we saw with that pleural effusion and the exudate.
So what would cause it to be like?
Infectious material. But it's different than a pleural effusion in the previous one that we saw.
Does that one hurt because it's thick?
No, you might feel pressure or short of breath because it's compressing up against the lung, but again, describing the kind of, you might do a needle thoracentesis just to get a little fluid out, and then you could analyze that. Oh, this is a chylous fluid or a chylous fluid, rather than pleural effusion.
So if that's the case, how would you drain it, or do you just let the body take it back?
It depends. If it's thick and waxy, you may have to go in and peel it away under a thoracotomy.
Do you have a video of that?
I don't. I've not found one. I'll see what I can find though.
Look it up.
Sometimes there's some pretty good ones.
A chylous
Thoracotomy.
Wait, what was it again?
It's
Thoracotomy.
called a thoracotomy, where they peel out a chylothorax.
Chylothorax.
Like open.
So I bet if we've done one thing today, we've kind of introduced you to the idea of lots of different kinds of chest infections.
Yeah.
Oh, no, I'm
You're okay.
distraction.
Okay.
Chylothorax.
That could also be blood. So if it's blood and not chylous fluid, what would we call that? Hemopneumothorax. Yeah. So hemo is blood. If that's after trauma, we might see blood there, and then it's a hemopneumothorax. So the types of abnormal secretions, what we get, and how it's evaluated is really taken together in a history and physical, the signs that the patient has, shortness of breath, the type of cough, what type of fluid it is, if it's mucus and secretions, if it's pleural fluid, if it's tracheal aspirate. If it's taken from a bronchoscope, or if we examine it with a chest X-ray to tell if it's in the pleural space or in the lung parenchyma itself, like an empyema or an abscess. So all of those things are taken into account when a patient comes to an office and says, I don't feel as well as I should. I've got this fever and I've got a cough. Well, then the practitioner starts, the point of all this is that in the assessment, when you're evaluating a patient that comes in with signs and symptoms that are consistent with something going on in the chest, it's how you go about the questioning. Questioning might seem way out of line. Well, do you raise birds? What do birds have to do with my cough and my shortness of breath? Well, it may have everything to do with the kind of cough and the shortness of breath you have, because the questioning helps to narrow the possibilities, and that's what assessment is. You, as a respiratory care practitioner, are going to be assessing all kinds of disease pathologies and signs and symptoms, and your role is to associate the types of things that the patient relates and try to come up with a plausible diagnosis. And that plausible diagnosis depends upon the questions you ask. Have you ever been to the Mississippi Valley? No, I've never been to the Mississippi Valley. If the answer is no, then it takes off the possibility of histoplasmosis. See what I mean? So the questions might be weird and unusual. Have you ever been to China? Because I'm thinking about H1N1. Or have you ever been to Southeast Asia? Because I'm thinking about bird flu. You see what I mean? So the questions, even though, even if they're answered negatively, that takes off a lot of plausible diagnosis that you may not think about if you don't ask the question. So sometimes the questions in addition to the laboratory tests, the signs and symptoms,
Yes.
the x-ray results, all of those things are taken together as a plausible diagnosis, and you ask questions that guide your discussion with the patient and help you to narrow down the possibilities. That's really what you're doing with assessment. So the questions become particularly important. Okay, I think I'll stop there. Questions?